Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Clin.
And today we're going to move forward with part 2 of our testicular cancer discussions, moving into stage 2 and later stage disease.
So if you remember from our last episode, even advanced testicular cancer has a pretty good prognosis, and there actually is no stage 4. So today we'll be talking about stage 2 and stage 3.
As a brief recap, for stage 1 disease, initial treatment is going to be orchiectomy, and that's going to be the case for any stage of testicular cancer, both from a diagnostic standpoint as well as therapeutic. The testicle is a sanctuary site, so even if we are using chemotherapy, it's not going to get there. So it would have to be removed no matter what. Often for stage 1 disease, the surgery alone is enough. However, for patients who are unable or unwilling to commit to the ongoing surveillance protocol, or for patients with high-risk features, especially in the case of non-seminomatous germ cell tumors, there may be a role for adjuvant therapy.
While most patients present with early stage disease, some patients will present with more advanced disease such as lymph node involvement or distant metastasis. For these later stages, it's important to risk stratify because this will help to avoid over or under treatment. Because as we said, many of these patients will have a good prognosis, and it's important to only treat the people that absolutely need it to avoid the long-term toxicities, given that this is a younger patient population. So just to recap, we spoke about the risk stratification last episode, but there's good, intermediate, and poor risk. For seminoma, there's actually only good and intermediate risk. There's no poor risk disease. And the easier way to remember this is that intermediate risk has metastasis to anything other than lungs or lymph nodes. And good risk disease is basically everything else. So anyone with localized disease or metastasis to the lungs or lymph nodes has good risk disease, and everyone else has intermediate risk disease. And just a reminder, for seminoma, everyone will have a normal AFP because by definition, if the AFP is elevated, that automatically makes you a non-seminoma. For non-seminoma, there's good, intermediate, and poor risk disease. Good risk disease is defined as testicle or retroperitoneal primary with lung or lymph node mets only, and AFP less than 1,000, beta HCG less than 5,000, and LDH less than 1.5, the upper limit of normal. Intermediate disease is also no metastasis other than lungs or lymph nodes, an AFP of 1,000 to 10,000, beta HCG 5,000 to 50,000, and LDH 1.5 to 10 times the upper limit of normal. And poor risk disease is anybody with a mediastinal primary, metastasis to organs other than the lungs or lymph nodes, and an AFP greater than 10,000, beta HCG greater than 50,000, and LDH greater than 10 times the upper limit of normal.
Pure seminomas can have a mediastinal primary. This is not poor risk. Poor risk is only a mediastinal primary with a non-seminomatous germ cell tumor. So it's important to keep in mind these different risk categories. These have a direct impact on prognosis, especially in stage 3 disease, and will dictate our chemotherapy regimen selection. So when we talk about chemotherapy, we're going to talk about regimens that would be used depending on the risk stratification. So moving into management of stage 2 disease, we'll start by talking about pure seminomas. And if you remember from our last discussion, pure seminomas are both very sensitive to cytoreductive therapies. And for stage 2 disease, which is involvement of retroperitoneal lymph nodes, often we can treat these patients with either radiation or chemotherapy and avoid the need of a retroperitoneal lymph node dissection, which can have a lot of short-term and long-term morbidity. Typically, if we have a low tumor burden, which is considered to be less than 3 centimeters of lymph node mass, radiation is preferable for stage 2 disease. This carries an 80 to 90% cure rate. The primary location for recurrent disease is distant, and this can be salvaged with systemic therapy down the road. If the lymph node tumor burden is greater than 3 centimeters, or if there's contraindications to pelvic radiation, such as inflammatory bowel disease, a horseshoe kidney, then we would choose chemotherapy over radiation. I think being aware of inflammatory bowel disease and horseshoe kidney, which aren't typically things we think about as being treatment selection pathways, are good to know, as these would make for very good high-yield questions. So now that we're talking about chemotherapy again, I think it's time to start actually going into detail on the chemotherapy regimens. So the standard regimens would be BEP, EP, or VIP. BEP is a combination of bleomycin, etoposide, and cisplatin. Bleomycin is given on day 1, day 8, and day 15. Etoposide is given as 100 milligrams per meter squared for days 1 through 5. Cisplatin is given as 20 milligrams per meter squared on days 1 through 5. And this is repeated on every 21-day cycle. We've previously spoken about cisplatin etoposide, but bleomycin is a new chemo that we haven't talked about in our prior discussions. So just very briefly, this is a DNA synthesis inhibitor. It's renally cleared and has some unique toxicities. Most commonly, patients will develop rash, and this might develop as early as 2 weeks after the infusion or maybe as late as 1 month after the infusion, so it can be a very delayed rash. It's a very myelosuppressive chemotherapy, and it's renally cleared, so any patients with renal dysfunction, we have to be aware of this. The unique and life-threatening toxicity of bleomycin is the risk of interstitial lung disease and the risk of late-term pulmonary fibrosis. Pulmonary fibrosis can be exacerbated by certain interventions such as high amounts of oxygen given through a nasal cannula or through a ventilation machine. It is dose dependent, so patients with reduced creatinine clearance do get a higher total dose and can be at higher risk. And patients who smoke will be at high risk for pulmonary fibrosis. It's very important to keep in mind the risk of high amounts of oxygen being administered, because if a patient may be someone who you're going to do a later on resection of a lung tumor or a mediastinal mass, you may not want to be using bleomycin in this patient because they might be at high risk for lung disease. One other thing I'll mention is, as this is a cancer that often affects young patients, you're going to have a difficult time measuring their creatinine clearance, as these patients often have very good kidney function and lean body mass. So you would consider in some of these patients to get an accurate measurement of creatinine clearance using a 24-hour urine creatinine measurement rather than a spot estimate based upon a BMP.
So for patients with good risk disease, BEP is typically given for 3 cycles and 4 cycles for intermediate or poor risk disease. So for patients with good risk disease who are not candidates for bleomycin, you do have the option of using EP, which is etoposide and cisplatin, so the same regimen as BEP without the bleomycin, for 4 cycles rather than BEP for 3 cycles. So there were randomized trials looking at EP versus BEP, and these do appear similar, with similar event-free survival and overall survival. Now, for patients with intermediate or poor risk disease who are not candidates for bleomycin, the chemotherapy of choice is VIP, which is cisplatin 20 milligrams per meter squared days 1 through 5, etoposide 75 milligrams per meter squared days 1 through 5, and ifosfamide 1200 milligrams per meter squared on days 1 through 5 with mesna.
Ifosfamide is another chemotherapy that we haven't spoken about previously. It's very closely related to cyclophosphamide, which we've spoken about previously in the case of breast cancer. This is an alkylating agent that is primarily renally cleared. The renal clearance is both with active and inactive components.
So toxicities that are unique to ifosfamide are hemorrhagic cystitis, which requires us to give mesna along with it. So you start it prior to the infusion and give it continuous with the ifosfamide. And you also want to make sure that you're checking your analysis on these patients and having them be aware of any signs of hematuria. Another notable toxicity is neurotoxicity, which can present in different ways, such as confusion, altered mental status, seizures, weakness, neuropathy, ataxia. So you want to make sure that patients are reporting any neurologic symptoms. And neurotoxicity can be more common in older patients greater than 60 years old. Another toxicity to be on look for with ifosfamide is, unlike BEP or EP, this is a more myelotoxic regimen, so you want to make sure that you're monitoring the blood counts, and we routinely use GCSF in this regimen, unlike BEP or EP, to avoid delays and avoid neutropenia.
The encephalopathy can be quite profound, although most commonly older people may present as acute confusion or even comatose state in younger patients. This is reversible in most cases, up to 50% are completely reversible. There's no evidence-based antidote for this. However, some experts recommend consideration of methylene blue. However, this has only ever been looked at in a retrospective nature, so it's unclear if patients would recover anyway or if there's any added benefit with methylene blue, but it is something that has been used in the past. Mesna works by helping protect the bladder until the active agents have completely cleared their way out. Along with mesna, we also give high amounts of hydration and encourage patients to drink lots of water. It's important to give mesna near continuously over a 24-hour period, and due to this, historically we had to give ifosfamide in an inpatient setting. So unlike the other 2 regimens discussed, patients would be admitted for 5 days straight to get continuous ifosfamide and mesna infusions. More recently, an outpatient regimen has been developed. It still is a very long infusion, so patients require an infusion that takes up the entirety of a day for 5 days in a row while receiving the ifosfamide. And during this time, they receive the IV mesna while in the clinic. And then when they go home, they have oral tablets that they take at home. Patients are going to be monitored with urine dipsticks each day to ensure that they're not having hematuria. Any presence of blood in the urine may be a reason to stop the ifosfamide. And gross hematuria is an absolute reason to stop the ifosfamide. VIP has been compared to BEP, and as far as long-term outcomes, is nearly identical. However, it's a more toxic regimen with both the GU and myelotoxicity. So BEP would be our preferred agent in most patients. So looking at stage 2 for non-seminoma germ cell tumors, this is broken down into stage 2A or stage 2B. Stage 2A are with less than 6 lymph nodes and all less than 2 centimeters in size, in which case retroperitoneal lymph node dissection is the preferred approach. As non-seminoma germ cell tumors are a bit more heterogeneous and there's a risk of teratomas, surgery seems like the best way to initially treat these patients. If the lymph nodes are greater in number or greater in size, or if the serum markers are elevated enough to fall into the intermediate or poor risk groups, then you would consider definitive chemotherapy with either BEP or EP.
So for stage 3 disease, which is anything beyond retroperitoneal lymph node metastasis, the treatment primarily depends on the risk stratification that we spoke about. For good risk disease, as we said, the treatment would be BEP for 3 cycles or EP for 4 cycles if not a candidate for bleomycin. And for intermediate or poor risk disease, the treatment is BEP for 4 cycles, and if not a candidate for bleomycin, VIP for 4 cycles.
It's worth noting that stage 3 disease is a spectrum, and sometimes patients can show up with quite profound extensive disease. With lung metastases, this may lead to hemoptysis, and with CNS metastases, these can be hemorrhagic as well. So sometimes your initial process will be stabilizing the patient. If the cranial metastases are somewhat stable, the standard regimens, both BEP and VIP, do have CNS efficacy. Often with these patients, the chemotherapy alone can be still curative. So you can potentially avert the need for neurosurgery or radiation to the brain unless patients have residual disease after the initial course of chemotherapy. Another scenario on the metastatic site is the choriocarcinoma syndrome. So if you remember from our last discussion, choriocarcinomas can be very aggressive behaving. These are characteristically presenting with a beta HCG greater than 50,000, often with a mediastinal mass or testicular mass. And these patients may come in very, very sick. And although ultimately the diagnosis would be confirmed with an orchiectomy, you may not have time to get the patient in for an orchiectomy if they're having widespread disease, in which case you would start a cycle of BEP or VIP first prior to having the orchiectomy performed. Having widespread metastatic disease in a young male patient with a palpable testicular mass or a mediastinal mass seen on imaging and a beta HCG greater than 50,000 is diagnostic for choriocarcinoma syndrome.
It's also important to note that women can also have choriocarcinoma, particularly after pregnancy, and that can also be devastating and present very aggressively. So after a patient completes adjuvant treatment for stage 2 or stage 3 disease, there is a surveillance protocol which includes checking tumor markers and repeating imaging to assess for residual disease. If there is residual disease on imaging, there are certain protocols to follow to determine the next steps. Oftentimes this is not actually residual disease and usually represents necrosis or fibrosis, and sometimes can also reflect a teratoma, which, as we said, is not particularly sensitive to chemotherapy. If the masses look like they are growing, then you would proceed to second-line treatment. And the next steps depend on if you're dealing with a seminoma or non-seminoma. For seminoma, if the residual masses are greater than 3 centimeters, you would proceed with the PET-CT. And if this is positive, then you can consider biopsy versus resection and consideration of additional cycles of adjuvant chemotherapy. For non-seminomas, there's really no role for PET-CT because teratomas will not really show up on PET-CTs, and it's hard to distinguish this from fibrosis. If the lymph nodes or mass are greater than 1 centimeter, you would proceed with the retroperitoneal lymph node dissection or resection of the mass, both for pathology and to see if additional chemotherapy is necessary, as well as to remove the residual malignancy.
So fortunately, the outcomes for these patients, even with stage 3 or metastatic disease, can be very good. In the case of good prognostic tumors, we have greater than 90% long-term outcomes. Intermediate risk patients have a greater than 75% chance of remaining alive at 5 years. Poor risk, unfortunately, does have a worse prognosis. That's less than 50% at 5 years. So although most patients do well, a number of patients do have refractory disease, and then we need to start thinking about what do we use as later line options. So if a patient did not have a full course of BEP, namely they have not received all 4 cycles, which might be the case in some of the adjuvant or earlier stage protocols, then you would give the patient BEP later on. Other options include transitioning to VIP or TIP, and TIP is paclitaxel, ifosfamide, and cisplatin. There's other options including combinations of vinblastine, etoposide, and cisplatin as well. There is an active debate after someone has progressed on their second line of chemotherapy on how to best proceed. And one of the options out there is the consideration of high-dose ablative chemotherapy followed by autologous stem cell transplant.
So just to talk briefly about autologous stem cell transplants, because I don't think we've discussed this in detail. There are 2 types of transplants: autologous stem cell transplants, where you're using your own stem cells, as well as allogeneic stem cell transplants, where you're using stem cells from a donor. Now, I find that when trainees learn about stem cell transplants, we automatically assume that the stem cells are providing the ammunition to fight the disease. And that is more the case with allogeneic stem cell transplants. For autologous stem cell transplants, really the only purpose of the stem cells is to allow you to give high doses of chemotherapy that will completely ablate the bone marrow. And without the stem cell rescue, the bone marrow would never recover. So many people call this autologous stem cell rescue because really you're just giving your own stem cells to help regenerate the bone marrow after giving very high doses of chemo. Now, as Ryan said, there is controversy using this in testicular or in refractory germ cell tumors. The limited data that we have is pretty mixed in terms of efficacy compared to standard chemotherapy. One of the only phase 3 trials that we have, which included almost 300 patients and randomized patients to either VIP or VEIP, which is vinblastine, ifosfamide, cisplatin for 4 cycles. That was compared to 3 cycles of those same chemos with 1 cycle of high-dose carboplatin, etoposide, and cyclophosphamide, followed by autologous stem cell rescue. This showed actually a similar 3-year event-free survival, 42% versus 35%, and not unexpectedly a higher mortality with the autologous stem cell transplant, 7% versus 3%. Now, observational studies have shown increased progression-free and overall survival with the use of autologous stem cell transplants. However, those, as we said, are observational, and there hasn't been any large-scale randomized data in support of autologous stem cell transplants.
In terms of that earliest randomized controlled trial that Ryan talked about there, the 3-year overall survival was almost identical, 53% in both arms. Interesting though, however, the patients who did have a complete response to their stem cell transplant did have an improved 3-year disease-free survival of 75 versus 55% in the complete responders in the non-transplant arm. So there's maybe an argument that on the margins, the patients who do the best in stem cell transplant do have a longer-term response than those who do the best without the stem cell transplant. One of the natural questions, and what's been tried in some of the retrospective studies is, well, if one transplant is okay but not enough to overcome chemo, why not give more transplants? And that's kind of led to some practices using what's called tandem transplant, where we give high-dose ablative chemotherapy, typically nowadays with carboplatin and etoposide, allow the marrow to recover after the transplant, and then put a patient through that same process again. However, this has not yet been looked at in a randomized controlled setting. There were different ablative chemotherapy regimens looked at. At least one study compared carboplatin etoposide compared to the original carboplatin etoposide and cyclophosphamide regimen. 3-drug regimen did have a significantly increased mortality or short-term morbidity compared to the 2-drug regimen in a randomized controlled trial published in 2007 with 16% deaths related to cardiac toxicity at the time of transplant. So if you do select transplant for your patient, you'll be typically using carboplatin and etoposide, unless it's on a clinical trial. If you decide against or don't have access to the enormous expense that a transplant brings on itself, other therapy regimens are out there, and often this is going to be either two drug or single drug chemotherapy regimens, such as gemcitabine and oxaliplatin, paclitaxel, single agent etoposide, and these would often be continued until progression. Because this is a cancer that is curable in the vast majority of patients and also tends to affect young patients, I think this is a good time to go over the concept of survivorship. In all cancers, there's evidence out there on survivorship protocols, which means patients are living cancer-free now beyond the time when their cancer typically would come back, at which time we really should start putting our sights on managing potential increased harms that these patients are at risk at from the treatments that we gave to them in the first place. In the case of patients with testicular cancer, these toxicities may be related to the chemotherapy, the radiation, or the surgery. We've mentioned the toxicities of retroperitoneal lymph node dissection previously, but even just having an orchiectomy can have long-term toxicity, as patients have hypogonadal syndrome, which can lead to things such as metabolic syndrome, obesity. Furthermore, patients may be at increased risk for cardiac harm, as cisplatin can be cardiotoxic, especially many years out. And it's very important to be monitoring these patients for things like hyperlipidemia and hypertension and diabetes. As oncologists, we're expected to be familiar with some of these late-term toxicities, and we should have a process in place to communicate with the primary care physicians who are ultimately going to be following these patients down the road. Some cancer centers actually have built-in survivorship clinics, both for pediatric cancers as well as testicular cancers, but that sort of resource isn't available everywhere that you may practice.
As with many chemotherapy regimens, these patients are also at risk for secondary malignancies, particularly hematologic malignancies such as AML.
Other long-term toxicities to consider are the lung toxicity, as we mentioned with bleomycin, and although most of the interstitial lung disease happens early on, pulmonary fibrosis may become clinically impaired months or years after the treatment's been administered. Also, neuropathy and ototoxicity from cisplatin. Lastly, mental health is something that we have to be aware of. Having an illness as severe as this and going through treatments such as intensive chemotherapy, lymph node dissection, radiation can be traumatizing to young patients. And often, sometimes the impact on mental health may not arise during the course of treatment. And this is the case for anytime we're giving cancer care over a short interval and then moving into the follow-up state. Often people go through the motions. They're going back and forth to the hospital and clinic and don't really have time to think during the course of therapy. And then when the treatment ends, often then they have time to reflect on what they've just been through and the future in front of them, which can be pretty overwhelming. So it's important to be mindful of this and ensure that our patients are coping well and have the resources needed to succeed after becoming survivors and moving on with their life.
Yeah, I've seen this a lot in the breast cancer world with adjuvant chemotherapy, that patients are doing well going through the treatment, and it's not until after they're done that it really hits them with what they've been through. And that's when they often require more emotional support. Okay, well, I think that wraps up our discussion. I know that was a lot and kind of a whirlwind, but time for some bottom lines.
For stage 2 disease, in the case of seminomas, we're often going to be looking at either radiation for a lower tumor burden or systemic therapy for a higher tumor burden as being a definitive course of care. For stage 2 non-seminomatous germ cell tumors, the initial approach most likely will be a retroperitoneal lymph node dissection, but once again, for elevated tumor markers or a higher tumor burden, chemotherapy would be our initial approach.
For stage 3 disease, the treatment really depends on the risk stratification. For good risk disease, we're looking at 3 cycles of BEP, or 4 cycles of EP for patients that are not bleomycin candidates. And for intermediate or poor risk disease, we're looking at BEP for 4 cycles, and for patients that are not candidates for bleomycin, VIP for 4 cycles.
For patients with mediastinal tumors or extensive lung metastases where you think you may be attempting salvage surgery down the road, these would be patients you would lean towards VIP over BEP.
For patients who are refractory to first-line treatment, second-line options include additional chemotherapy regimens such as TIP, paclitaxel, ifosfamide, cisplatin, or other combinations which include vinblastine.
If they progress through 2 lines of treatment, your options will be moving into sequential, single, or doublet chemotherapy regimens, using a triplet that you haven't used already, or consideration of ablative chemotherapy with stem cell rescue.
And survivorship is important given the young patient population. So important to screen for long-term chemotherapy toxicities as well as mental health issues going forward.
Thank you for listening along. This wraps up our discussions around the GU topic. Next, we'll be moving into sort of a grab bag covering tumors such as hepatocellular carcinoma, neuroendocrine tumors, glioblastomas. Please, if there's a tumor site that you think is high yield and we haven't covered, let us know. We're happy to include that as well.
And I think it's that time of year that the boards are coming up, so good luck to everyone taking the boards this year.
Bye for now.
Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.